Uh, the principles, as I said, is primarily not only to control disease, but it is also very important that we maintain organ and function. And radiation therapy, as you've heard, is not only helps in improving disease control, but is also associated with toxicity. And this is of greater importance in children because of the adverse effects of radiation that you can see in these very young children. I have no disclosures. Um, Now, soft tissue sarcomas, when you say, is a whole large group of various histological subtypes. But what is very distinct is that in the younger age group, you would see the round cell subtypes, whereas in the slightly older age group, you would see the non-round cell soft tissue sarcomas. The other very distinct thing that is visible from this slide is that almost 60% of the patients would have soft tissue tumors involving the extremities, and the remaining would involve the centroaxial skeleton, the retroperitoneum, the head and neck region. So literally you can have all sides of the body that could be involved by soft tissue tumors of either histological subtype. We know that round cell tumors are extremely sensitive to radiation, and the non-round cell tumors are slightly less sensitive to radiation therapy. We also know that radiation therapy has been extensively used and very effectively used in the round cell tumors, whereas in the non-round cell tumors, it's been a bit controversial, and the data primarily comes from the adult population of soft tissue sarcomas. But if you look at the European and the American data, this is the Children's Oncology Group risk stratification and treatment policies. You would see that in all three groups, the low risk, intermediate, and high risk, there is still a large role for radiation therapy. Now, I just looked into the data that is available for children treated with soft tissue sarcomas. This is relatively rare, and this is a conglomerate of both American and European groups. This is a cohort of 304 patients. What I want to highlight here is that the importance of using radiation therapy as an adjunct to surgery, especially in the non-round cell soft tissue sarcomas. So what was seen in this cohort of patients is that the patients, when you did not use radiation therapy for whatever reasons, the outcomes in terms of local controls and survival were inferior. Now, just for the non-radiation oncologist here, what do we do in brachytherapy? Brachytherapy is a form of radiation therapy where the radiation source is actually inserted either into the tumor bed or kept very close to the tumor bed so that you could radiate the tumor bed to the required dose. The benefit of radiation therapy, that is brachytherapy, over external beam radiation is that there is a very rapid fall off of dose beyond the tumor bed, and because of which you are able to spare the surrounding normal structures, and that is expected to reduce the adverse effects of radiation. In the next few slides, I'll just take you through some examples of soft tissue sarcomas where we have used interstitial brachytherapy in our own institution. Now, this is a young kid with a high-grade tumor of the upper extremity, and as you can see, it is very close to the wrist joint, also the vessels. And after an excision, it would mandate radiation therapy, and we prefer to do interstitial brachytherapy in these children. The benefit is that you could not only treat the tumor bed to the appropriate dose, you would be able to spare the surrounding joint and also the vasculature in that same region. Another example of a very young child with a soft tissue tumor, as you can see in the MRI, close to the tibia and fibula. This was excised, and post-excision, the tumor bed literally exposes the tibia and the fibula, and the tumor bed actually lies very close to them. So external beam radiation to this area would would result not only in disease control but also a very high likelihood of bony growth defects in the long run. So we did brachytherapy. You can see that the brachytherapy needles are inserted into the tumor bed. The compliance of these kids are extremely good if they are explained well, and you can see the results of treatment. If you can see here, the functional outcome. Unfortunately, I'm not being able to play the animations that would have shown you the functional outcome in this child. So this was the end result on follow-up. There was no bony defect, and the functional outcome was extremely good. Another young child who came with a high-grade sarcoma close to the ankle joint, which was excised. He was a very tiny 6-month-old kid, 6 to 8-month-old kid at that time, excised, high-grade tumor, and we did brachytherapy. And this is the kid on follow-up. And now he's almost 14-year-old, and he's doing extremely well with extremely good functional outcomes. So we were able to not only control disease but also preserve good function. Now, proximity to neurovascular bundles is considered a relative contraindication for brachytherapy, but with experience and with appropriate care, you could do interstitial brachytherapy for tumor beds which are very close to the neurovascular bundle too. This is an example of such a young child who had a tumor, high-grade tumor, excised, and we did interstitial brachytherapy. Sparing the growth cartilage is extremely important. This kid had a tumor close to the knee joint. It was excised, and as you can see in the scan, it was very close to the growth cartilage there, and external beam radiation therapy would have led to significant growth deformity. So we did interstitial brachytherapy, and we have technologies now available to us to reconstruct the bone, reconstruct the nerves located here, and even the growth cartilage, and modulate our radiation therapy and brachytherapy in such a way that you could prevent damage to the growth cartilage. This is an unusual site for brachytherapy. And normally, we would not go through the interosseous areas to avoid injury to the vessels and nerves. We didn't have many options, and external RT would have caused bony defects. So we did brachytherapy, as you can see in this picture, and the functional outcomes were extremely good. What about the disease outcomes? This was our original publication in 2008. Our local controls for the whole group was 82% at 50 months of follow-up. And the prognostic factors were the standard prognostic factors. And what was important here is that when we used brachytherapy alone, the disease controls were more or less similar to when we used brachytherapy and external beam radiation therapy. So that was a way by which we could reduce the complications of radiation therapy. Now, this is a nice paper by Arnold Polino from Emory, and he looked at the bony defects caused by radiation therapy in this relatively large cohort of patients with a long follow-up, and bone abnormality and bone growth abnormality was a major problem. Now, in these kind of situations, when you have a PNET of the metacarpal bone with a large soft tissue component, you would require post-op adjuvant radiation therapy, and external beam radiation therapy would lead to significant functional deficit. We did interstitial brachytherapy for this patient, and we were able to spare the normal structure as the normal bone surrounding the tumor bed effectively, and the functional outcome was extremely good. I don't know whether you're able to see the video. The patient had extremely good functional outcome, and his disease was controlled on last follow-up. Normally with plastic reconstructions, especially if you have a pedicle graft, the surgery becomes technically challenging, and also there could be a functional compromise. And generally, we would avoid using interstitial brachytherapy in these patients. We've started recently doing brachytherapy for children and adults with the skin grafts done for closure of the of the skin defect, and we have had good outcomes in terms of disease control and also functional outcomes. Moving on to the head and neck area, head and neck is more challenging. This is an example of rhabdomyosarcoma in the parameningeal area, and you treat it with external RT. But in certain areas, you could use brachytherapy very effectively to reduce the morbidity of treatment. This was a young child with a rhabdomyosarcoma of the eyelid. External radiation would have caused toxicity in the form of cataract, keratitis, and also a bone dose. So we used interstitial brachytherapy to reduce the dose to surrounding structures, and this kid has done very well in terms of disease control and also function. Some of you have seen this child earlier. I have shown we've started doing brachytherapy for tumors of the orbit. A very young child with a alveolar rhabdomyosarcoma received chemotherapy, would definitely require radiation. So we did interstitial brachytherapy for this child, and you can see this is how well we could avoid radiating a large volume of the orbit, and we could conform our radiation dose to the tumor itself and avoid dose to optic nerve and also to the lens. This is how the brachytherapy needles are kept in place. And we did also compare the dose of radiation delivered to normal tissues using brachytherapy vis-a-vis external beam radiation therapy. And we did see that there was a significant reduction in the dose to the normal structures if we did interstitial brachy. Disease outcomes extremely good at the end of 3 months, this one, and the functional outcomes you can see in this picture. Brachy has been used for other sites also. There is a very active group in France doing brachytherapy for tumors involving the prostate and the bladder neck, and they have had extremely good outcomes using interstitial brachytherapy to a dose of 20 gray with or without external beam radiation therapy. And their local failure rates have been in the tune of less than 10%. We've done a few patients of prostate and bladder rhabdomyosarcomas. This is an example for a bladder rhabdomyosarcoma, surgically excised after induction chemotherapy. And we did brachytherapy to restrict the dose to the bladder wall and avoid doses to the pelvis of this very young child. Rhabdomyosarcoma of the vagina in very young child. It is important that we avoid toxicity to the surrounding areas, at the same time achieve a good disease control. You can see how well we could restrict the dose to the vagina and avoid any dose to the bladder, rectum, a very little dose to the bladder, rectum, and almost nil to the bony pelvis. So one of the things that is important is to avoid recurrences even in these young children. Although we would be tempted at times to avoid radiation therapy, but the results show that it is important to use the right techniques, and especially brachytherapy would be useful in these very young kids to optimize disease control and prevent toxicity of treatment. These are true studies where they showed extremely good disease control using brachytherapy with local relapses of about 16% and overall survival of 90%. To finish off, just to share our outcomes with interstitial brachytherapy in pediatric tumors, we have a large series of patients. Important thing is that we have been able to treat younger kids as we have gained more and more experience, and our toxicities have been very low. We'll soon have our proton therapy center functional, and so that would be a time when we'll have to probably look at and choose which are the patients who would benefit with brachy, at the same time see the ones who would benefit more with the proton therapy. But there are certain things here. If you look at the cost of treatment, there's a big difference with protons. The cost in the United States would be anywhere between 100 to 150,000 US dollars, whereas brachytherapy and TMH would be about 450 US dollars. So that's the cost part. So just to summarize at the end, brachytherapy helps optimize disease control and reduce toxicity, and definitely helps in preserving good function when chosen and when the patients have been chosen in the right way for the right indications. The biggest advantage is, besides having good disease control, uh, the overall treatment time for the patients is very short compared to external beam radiation therapy. Concurrent treatments can be started very easily without the worry of adverse effects of treatment. It's relatively less expensive, but there are certain downsides that one has to be careful about. The target volume coverage. You could injure bundle if we are not careful, and of course there is a learning curve that is always associated with a specialized technique like brachytherapy. So thank you very much for your time, and I will be happy to take questions at the end.